The development of this podcast was sponsored by Alexion Pharmaceuticals Incorporated. The viewpoints expressed are those of the person speaking and not of Alexion. Welcome to NMOSD Your Way Global, an educational podcast series for NMOSD patients worldwide. NMOSD stands for neuromyelitis optica spectrum disorder, a rare relapsing autoimmune disorder of the central nervous system which primarily affects the optic nerves and the spinal cord. Your podcast hosts Lesley-Ann Hall and Debbie Leticq, who have both lived with NMOSD for over 10 years, will be bringing their respective Canadian and Australian perspectives to the table in order to help patients worldwide better understand NMOSD. Over the next 16 episodes, clinicians, researchers, and fellow patients will come together to have important conversations about how to live your best life within your diagnosis. They will be offering up encouragement and practical tips for overall health and well-being. In this episode, Debbie is joined by Neurologist Dr. Lesley-Ann Hall, and they tackle the tricky topic of relapses. So, let's get started.
An NMOSD relapse can be quite frightening. I know firsthand what it's like and have some serious implications, but being aware of what to expect can help. In this episode, I'm talking to neurologist Dr. Lesley-Ann Hall about NMOSD relapses. Thank you once again for joining us, Dr. Lesley-Ann Hall. Looking forward to having a chat with you again today.
Well, thanks for having me, Debbie. It's a pleasure to join you.
For our first question, can you explain what an NMOSD relapse is?
So a relapse of NMOSD is a distinct episode of new inflammation that occurs within the central nervous system. And it may or may not cause people to experience new symptoms or potentially worsening of pre-existing symptoms that they may have already experienced. And really the symptoms that they experience depend on whereabouts in the brain or the spinal cord that the inflammation is affecting.
The signs and symptoms of a relapse are quite unique to each individual, but what are the typical symptoms someone might be experiencing if they are having a relapse?
Yeah, and there's certainly a number of them that it may be. They're generally quite abrupt and rapid onset, so they're not things that develop over months. It's usually a very short period of time, and they typically will reach their peak intensity within a few weeks' time. Now, sometimes those symptoms may be preceded, let's say, by some nonspecific symptoms, febrile illness, for instance, headaches, fatigue, muscle aches, maybe some gastrointestinal or upper respiratory tract symptoms, but they generally will precede these very classic symptoms of NMOSD. So the first one, which most people may be aware of, is things like visual loss, which can typically affect either one or both eyes at the same time. It can be quite painful, particularly when you're looking around. There may be a loss of color vision or double vision, for instance. Another symptom people may experience is either motor deficits, so weakness involving one side of the body or another, or sensory change, so that could be numbness, pins and needles, sometimes nerve pain, which we classically describe as that really sharp, stabbing, electric shock-like radiating pain that travels from one part of the body to another. Sometimes that can actually feel like you're being squeezed from behind, like someone's coming up and giving you a bear hug as well, that tightness around your chest. For some people, the first symptoms they may experience might be bladder or bowel symptoms, so some difficulty passing urine, perhaps not being able to pass urine at all, constipation or a lack of control over the bladder or the bowel movements. In certain cases, it may involve episodes of severe nausea or vomiting and intractable hiccups, the ones that you just simply can't get rid of despite drinking a glass of water upside down while standing on your head. And in certainly some severe cases, it can cause some breathing difficulties and respiratory compromise. People may experience one of these symptoms, they may experience many of them, and they could be at all the same time, depending on whereabouts the inflammation is occurring. And I guess it's really important that if you are experiencing new symptoms that are lasting for generally more than 24 hours, even if it's a worsening of a pre-existing symptom that you've had, but it's ever so slightly different, it's always better to see someone and have that assessed, whether that's with your GP, with your neurologist, or a treating team or a nursing staff, even if it's out of hours. So 3 in the morning, unfortunately, NMOSD doesn't differentiate between daytime and nighttime in terms of when it may present. At any time of day, it's important to get those things checked out if you're concerned.
What are the effects of an NMOSD relapse?
Well, the main effect that we see on the body is damage from the inflammation within the brain and the spinal cord, and that damage is irreversible. Our brains have this beautiful, lovely capacity to compensate for damage, particularly when we're younger. But even that reserve capacity gets tested in NMOSD, and particularly when that damage is severe. So what we try to do is prevent relapses and therefore prevent the inflammation that causes that damage. And by doing so, we hopefully aim to prevent the disability that occurs with relapses. And it's that disability that affects people in the long term for the rest of their lives, potentially.
Okay, so it is very important. Once again, we always go back to, if you're unsure, make sure you contact the hospital or your neurologist to get this checked out.
Absolutely. The earlier that you can treat a relapse, and recognizing it is a relapse is one of the first key steps to that. But the sooner that you can seek review by your treating team and be initiated on acute therapy, hopefully will help limit that damage and thus limit the disability that that damage has caused.
I know when I was having my first relapse, I actually got my daughter to film, as horrible as it was, to film me having a relapse so that I could initially send it to my neurologist to have a look at. And he was grateful, interested, and I then also used that video to share it with friends and family so that they could actually understand what a relapse looks like, because they normally see you quite well. What can be done for a person having a relapse?
Well, really initiating treatment early on in the course of a relapse is probably the key to limiting long-term damage. So early recognition, as we said before, actually recognizing that you are experiencing a change. Something's different. Something's not right. I shouldn't be having this double vision. I shouldn't be having this numbness down one side of my body. Recognizing that is the first step. And then subsequently confirming that it is a true relapse is key. And that's done following review, usually with either your GP or your neurologist. Nowadays, we certainly supplement that with an MRI scan with the aim to demonstrate that we have new focus of inflammation in the central nervous system. Sometimes we require supportive tests, sometimes not. It depends, I suppose, on the actual relapse that people are experiencing. That could be blood tests, it could be lumbar punctures, it could be reviews with the eye doctors, for instance, to clarify the findings. If we can confirm that there is a true relapse, there's new inflammation there that we need to treat. And I guess, Debbie, I think it's really important as well that we look at combining all of that within the background, having some good supportive holistic care. We talk about multidisciplinary team approaches. You may have heard of those. And it looks at treating the person as a whole. So we're not just treating inflammation. We're not just treating NMO. We are treating you, Debbie, as a person who happens to have NMOSD. And that might mean managing coexisting complications, so things like neuropathic pain, optimization of the bladder and bowel dysfunction that may come with it, managing your vision symptoms. It involves preventing complications that might come as a result of being in hospital and needing therapy. So preventing you from developing clots in your legs, for instance, when you're not up and moving around as much and you're getting these various therapies. It focuses on recovery. So utilizing the resources of the rehab teams, the allied health professionals, the physios, the occupational therapists, the speech pathologists, the social workers, in terms of accessing things like long-term support. If we rewind to a time when we didn't have effective therapies and we didn't have treatment options available, we knew that the natural history of NMOSD was one of continued relapse and continued disability. And within 5 years of people being diagnosed, many of them, up to 50% of them, were either blind or wheelchair bound. And 1 in 3 within 5 years were facing the prospect of death from this condition. So certainly the importance of treating it, recognizing it first of all, and treating it early, and then starting on to these treatments that can reduce that risk is really important. Look, we know that other things that can increase the risk, unfortunately, being female, if you have a history of previous attacks within a very short period of time, that unfortunately does mean that you might be at a higher risk of having more relapses in the near future. There are certain other conditions, things like coexisting autoimmune conditions, that can increase the risk of someone having relapses. So things like Sjogren's syndrome, systemic lupus erythematosus, or SLE, Hashimoto thyroiditis, various connective tissue disorders, things like that. And there is also the suggestion that physical stressors on the body, so whether that's infections, for instance, can increase the risk of having a relapse.
And it's also important that once you start treatment, even if you haven't had a relapse for many years, to continue with that preventative medication.
It is really important once you start on your therapy that you do continue on with it. Now, that's not to say that you might not necessarily change your therapy depending on how you tolerate it, depending on how it affects you, depending on your own personal circumstances, for instance. And that should be done in conjunction with your neurologist. I think regardless of whatever treatment it is that you are on for your NMOSD, you're taking a considerable step forward in the right direction to managing this condition in the long term.
Thanks, Lesley-Ann. I know for myself, my first and second relapses were actually presented quite differently. Is there a difference between the first relapse and subsequent relapses?
Okay, I suppose the first relapse we know often typically affects the optic nerves more than any other area. So as neurologists, we are very mindful when someone comes in with optic neuritis as potentially a first presentation that we need to be considering NMOSD as part of our diagnostic workup. But Debbie, as you said, I mean, we know that NMOSD relapses are very unique and can affect different people in different ways, depending on whereabouts the inflammation is and how severe it is. So no two relapses will often ever be the same.
Is it possible to recover from a relapse?
Well, while recovery is possible, there's certainly a cohort of people that will recover fully. There's a cohort of people that will experience a partial recovery from the symptoms. And there is, unfortunately, that cohort that will experience continued long-term disability as a result of that relapse. We know that with acute relapses, the recovery is very typically front-loaded. So meaning that often you will make quite considerable gains in recovery early on after the relapse. Certainly if we initiate therapy quickly and hit the relapse hard, we aim to minimize that damage. So we know that within really the first 6 to 12 months is the time when we see most recovery happening after a relapse. But realistically, that can continue on for up to 2 years. That's part of the reason why we try and maximize the supports that we give to people early on after a relapse. So things like the rehabilitation team, the multidisciplinary approach to treatments that we spoke of earlier. realistically, every relapse, again, being unique and being impossible to predict the severity of the relapse and therefore then the potential for recovery, it really depends on the amount of damage that's occurred and whether or not the nervous system can compensate and develop new pathways to compensate for those that are damaged.
Now, we've talked about relapses, but we haven't mentioned the word a flare-up. So I know that within the NMOSD community, we get asked that quite often. What is the difference between a relapse and a flare-up?
So a flare, or what sometimes people may call it a pseudo relapse as well, would be one of transient worsening or an exacerbation of pre-existing symptoms. So those that people have experienced beforehand in the setting of a true relapse. And I think the important difference is that it's often due to circumstances other than true new inflammation within the brain or the spinal cord. So triggers for that might be external stressors. So certainly heat, those really hot, humid summer days. A lot of people really struggle with, for instance, physical stresses, sleep deprivation, pain, infection, even the response to your COVID vaccination, for instance, can cause transient worsening of symptoms, for instance, vision symptoms or pain or weakness, but they are just that. They're transient. They're not due to new inflammation. They're not true relapses. And it's very common for people to experience those in their own unique way. So the triggers that, for instance, you might experience a flare with, some other person with NMOSD may not experience any worsening of symptoms at all, but they might have their own unique triggers for that. Importantly, a flare is not an indication of whether or not your long-term treatment option is working. So keeping in mind long-term preventative therapies, those disease-modifying therapies that we use, are just that. They're disease-modifying preventative treatments, and they stop new inflammation. But they unfortunately don't prevent those stresses on the nervous system that precipitate those symptoms due to the pre-existing damage that's there. The fact is, Debbie, it's really hard sometimes to tell the difference. And I'm not sure if you've ever been in that situation where you weren't sure. And I'm sure many of the people listening probably could relate to that. Sometimes the only way we know is by looking at supplementary investigations, things like MRI scans, to see whether there is new inflammation. I think the take home, I always say to people, you know your body better than anybody else. And if something isn't feeling right and you can't quite pin it down, it's always better to have it checked out, whether that's seeking some input from your GP, seeing your neurologist, seeing one of the clinic team, even if it ends up being a flare and it's not a true relapse. At least it will give you some comfort and peace of mind to have it checked. And it's going to take, people who are diagnosed with NMOSD, it's going to take some time for them to actually adapt to that new normal. And nobody is expecting you to be an expert overnight. It takes time. And for that reason, I always recommend, if you're not sure, if you're concerned, if you have new symptoms, again, that develop over that 24 hours or so, that maybe are new, or maybe they're worsening symptoms of the pre-existing ones that you've had, and you can't identify things that are obviously clearly triggering it, it's always better to have it checked out.
Some really good information there. Thanks, Lesley-Ann. I really thank you for your time and your input. Your information has been fantastic. I wish I had this information when I was first diagnosed. I hope it dispels some concerns that people have around relapses. So thanks very much.
You're welcome.
We hope you have enjoyed listening to this NMOSD Your Way Global podcast. For more information about NMOSD and access to support and resources, please read the podcast description. What you have heard in this podcast may not be reflective of your own experience and does not replace the advice of a healthcare professional. If you have any concerns or specific questions about NMOSD, please speak to your physician.